Hey everyone, how's it going this morning? You guys can hear me, let me know. Look like I have anyone watching. Or very few people. Anybody at all out there? Well, it's 8 o'clock and I don't have anyone actually watching. So I'm just going to go ahead and get started. I'm not sure if everyone forgot we have class today or what. Perhaps I'll make a quick. Alright, well, it looks like I only have one viewer. I'm not sure who that is, but not announced themselves in the chat, so that's okay. I'm just going to go ahead and run through the rest of the material that we have, and hopefully if anyone joins in, they can ask questions later if they like. I am a little bit under the weather, so if I sound a little off, that is going on. Anyway, so last time we met, we were talking about all of our medications for like GERD, and we talked about our PPIs and H2 blockers and stuff like that. Want to follow up with talking about some of our antiemetic drugs or stuff we're going to be using. Patients are nauseous, if they're having vertigo or dizziness that's leading to nauseousness, things like that. The things that can help out with that. And there, you'll see there's kind of a variety of different medications that can be different mechanisms that can help out with that. And so you can see here, these are used for all kinds of things. So whether you work in the ER, you work in surgery, you work in hemonc, you're going to be using antiemetics almost everywhere for the most part. So we're going to find that it's a pretty complex sort of pathway here to actually cause that leads to nausea and vomiting actually occurring. So you can see that a lot of this is mediated centrally through the brain. There's something called the chemoreceptor trigger zone, or the CTZ, that's going to be a really important um, mediator of nausea, vomiting. You're going to see there's a lot of other interactions here, things like in the medulla. The GI tract itself can be directly irritated. And so all kinds of different ways that we can interrupt the system here. So just to make this a little bit bigger, you can kind of see that there's a lot of different neurotransmitters are also involved in this. So for instance, you have things like serotonin, which is frequently abbreviated as 5-HT3. It stands for 5-hydroxytryptamine. That's serotonin. So if you have serotonin being activated, that can lead to nausea and vomiting. Dopamine can cause this as well, along with things like acetylcholine acting on muscarinic receptors. So if we can find ways to try to interrupt this, then that's going to be a very powerful way to try to prevent nausea and vomiting from occurring in our patients. So let's start talking about the first class we have here. So we have things like antimuscarinic and antihistaminic drugs here, some of which we've already talked about. In terms of drugs that are only antimuscarinic, this is actually going to be scopolamine or transdermscope, which is a frequent transdermal product you might see. I'm going to move this picture up so that way my big head's not blocking the thing I want you all to see. Blocking muscarinic receptors up in the brain is actually going to be pretty helpful to stop nausea, vomiting, especially due to things like motion sickness. So you'll see this recommended pretty frequently for patients who are going to, say, for instance, going on a cruise. Now, I know it sounds pretty odd that anyone would go on a cruise, but I guarantee you at one point in time before COVID, those things did happen. And so this would be something you could actually put behind the ear, and within a couple of hours prior to them getting onto the boat, it would actually help to prevent that motion sickness from happening. Because when you're on a boat, basically, especially like a large cruise ship, the boat may be moving, but your eyes aren't really telling you that. And so if there is a mismatch between what your vestibular apparatus is telling you in terms of movement versus what your eyes are saying, there's a mismatch there. That can cause some significant nausea and vomiting, so or seasickness. And so that's why we like to use scopolamine, because that can actually help to block that pretty easily. We do this a lot in surgery too. This helps to prevent things like postoperative nausea, vomiting. It also helps because antimuscarinic drugs tend to be a little bit sedating, so that's good for a surgery perspective too, as your patient's going back to have a procedure. Anyway, with transdermscope, you're only applying it once every 3 days. So again, for going like on a 3-day cruise to the Bahamas, no problem. You just need one patch and then you're good to go. One really important thing to note is that you need to wash your hands after utilizing the medication. If you don't, then you can end up doing things like rubbing your eyes, and then you can get this sort of interesting sort of picture here where if you saw one person had just one dilated pupil, you'd probably think they were having some sort of brain bleed or something. But missing any of their stroke symptoms, you'd have to dig a little deeper. And if you found out that they were using something like transdermscope, you can see that they were actually had just rubbed their eyes and didn't wash their hands very well. And so you can see this kind of a local effect just going and affecting one eye, almost as if you were doing an eye exam and you're using something like atropine in just one eye, or tropicamide and phenylephrine, or any of those cycloplegic agents we've talked about before. So other things you can run into as well with just the antimuscarinic actions here are going to be things like dry mouth, blurred vision, urinary retention. So it's good to remember that mnemonic for antimuscarinic actions. So remember, blind as a bat, red as a beet, hot as a match, mad as a hatter, and dry as a bone. Those are the common side effects you're going to see, and I think we've covered that before. But if you have questions, you can let me know. And then some drugs that have both antimuscarinic and antihistaminic actions tend to be a lot of our first generation antihistamines. So things like dimenhydrinate, meclizine, hydroxyzine, then certainly diphenhydramine, which I think most people are probably pretty familiar with. There is pretty heavy sedation and associated with these. So that's kind of one of the things you want to keep in mind, is that while some of these are available over the counter and they're easy to get access to, they're going to knock you out, which may not be good if you need to go, say, drive a truck as your job, or if you need to like stay up and listen to your pharm lectures or something. But certainly if you are trying to go to sleep for the night and you're nauseous, that could be totally fine. So any of these are reasonable. These are going to have additional benefit of being antimuscarinic and antihistaminic, so a little bit stronger effects there than just something like scopolamine might be by itself. Just kind of depends on the use case there. And again, all the same antimuscarinic side effects are going to apply here as well, so just kind of note that. Next, we have our anti-serotinergic drugs. And so, we've talked about different types of receptors in the past. We've talked about, beta 1 and beta 2 receptors, and H1 and H2 receptors. So we know there can be different subtypes of individual receptors. We're going to find with serotonin, it is probably one of the more diverse sets of receptors you're going to see out there. And I apologize for your kids screaming in the background. But you'll note that with serotonin, there's all kinds of variety. I think there's like over 15 different subtypes. And so we're going to find that keeping those straight is important because they can be used for completely different things. So, for instance, serotonin receptors that are responsible for mood, when we talk about depression, are different than what we're talking about with nausea, vomiting, which are different than when we're talking about migraine, for instance. A lot of variety of things we can use serotonin receptors for. Here specifically, we're going to be blocking the 5-HT3 receptors. So these are 5-HT3 receptor antagonists, and you'll see these work both centrally up in the CNS and also peripherally down in the GI tract as well. And there's three main drugs that fit into this category. Probably most of you have heard of at least ondansetron, which is Zofran. There's also dilaceron and then granisetron. I've never seen dilaceron used clinically, but certainly ondansetron is given much like water is down in the ER. That is something that almost everyone's going to get, and I'll talk about why in just a moment. And then granisetron is seen used for patients who are having chemotherapy related nausea. It's kind of a backup agent there. So especially if you're using something for like really highly emetogenic drugs like cisplatin, these can be really helpful. Now, in terms of their benefits here, they don't cause any sedation. So that's one of the big things. If you have someone that drove themselves to the ER and they're super nauseous and they're having belly pain or something like that, and then discharging them, they're much more likely to be able to drive okay if they got a dose of Zofran than they would if they got a dose of Benadryl, for instance. So that's one of the major benefits here. And for the most part, they're really well tolerated. I don't see a lot of patients have side effects from any of these anti-serotonergic drugs here. Headache, diarrhea, constipation. Okay, well, it's pretty non-specific. One thing you do want to note, though, and there's actually a black box warning on this now, is the fact that these drugs can cause QT prolongation. So again, typically when you see this, if it's a drug that's doing it by itself, probably not going to be a problem for most healthy patients, unless they have, congenital prolonged QT. But if you have patients who are on multiple QT prolonging drugs, that's where we want to start to be cautious. So imagine, if you will, somebody comes into the ER and they are complaining of, shortness of breath and their lungs somehow junky and they got a pneumonia, right? And you go ahead and give them something like azithromycin, right? They feel nauseous too, so you give them some ondansetron. When you start to combine multiple medications that can prolong QT, that's where you start to run a higher risk of having things like torsades that can develop. So especially if they're on chemotherapy agents that can prolong QT, if they're on, if they have electrolyte disturbances, any of that stuff you really want to be cautious with. So while I think most people think you can just give, ondansetron sort of, without any concern to any patient, there are rare cases we want to be more cautious about that. Okay, so the next neurotransmitter we could try blocking here is going to be our dopamine receptors, and these are going to be D2 receptors specifically. So these are going to be anti-dopaminergic drugs here. And so one of the big ones you'll see used most frequently is probably metoclopramide or Reglan. And then we have our phenothiazines as well. We're going to talk a lot about the phenothiazines in the behavioral health section coming up next semester. And so these are traditionally used as antipsychotic medications. We're going to find that when treating things like schizophrenia, a lot of that is mediated through dopamine receptors. And those same receptors are also causing nausea and vomiting. And so, again, for someone with schizophrenia, it doesn't mean they have constant nausea and vomiting, but it's mediated through the same receptors. So it makes sense that you can use medications have sort of similar mechanisms here. So metoclopramide is a good D2 blocker, and then things like prochlorperazine, which is compazine. I see this used all the time for patients with migraines. Providers get pretty good use out of this. Drugs like haloperidol or Haldol, and then promethazine or Phenergan. Promethazine or Phenergan kind of has a cultural sort of stigma associated with it. Frequently, you're going to find that it's in combination with another drug called codeine, which is an opioid analgesic, but also is an antitussive. And so if you ever heard of like purple drink or scissor, that's usually when drinking promethazine and codeine, which comes as a combo product, usually with something else as a mixer. I would recommend against doing that because you can have some pretty significant side effects from doing that. But perhaps some rappers might have different feelings on that if you go up search on purple drink. Anyway, so these drugs are working by blocking the D2 receptors, basically by antagonizing those in the chemoreceptor trigger zone. You're going to be helping to decrease that stimulus to cause vomiting to occur there in the medulla. Now, these are not used quite as frequently anymore. They do have quite a litany of side effects associated with them. Because not only are these going to have anti-dopaminergic activities, but they also are anti-muscarinic as well. So there is a lot of bleed over with some of the drugs we saw on a couple slides ago, like your scopolamine, like your meclizine, things like that. So certainly dizziness, fatigue, sedation, you're going to see that quite frequently in these medications here. Rarely you're going to see seizures. This would be more likely to occur in patients who have like a history of seizure disorder. I probably would avoid it in those patients there. Other things you can find too, and this depends on how frequently you're using it. If it's more of a long-term sort of thing, you can find issues of causing hyperprolactinemia. If it's a short course use of the drug, probably not going to run into that, but things that can do can cause things like menstrual cycle irregularities, can cause gynecomastia in males. We'll talk more about hyperprolactinemia a little bit later on next semester. There's also a rare thing that can happen here with this particular class of drugs here, like the phenothiazines, called neuroleptic malignant syndrome. Don't worry too much about this right now. We're going to talk a lot more about it next semester and talk about the mechanisms and stuff. But basically, one of the things you can find by giving some of these D2 blocking drugs, you can actually cause Parkinson's-like effects. And so, because if you look at the pathophys of Parkinson's, basically you're blocking dopamine receptors, or they're lacking dopamine. And so along that spectrum, you can develop something called neuroleptic malignant syndrome, which can be potentially fatal. It's rare that it occurs, though, and I'm going to talk about it at length next semester. All right. Another thing we could look at too are going to be our cannabinoids. And so this is basically going to be drugs that are mimicking the effects of THC, right? So we have two here. We have dronabinol and then nabilone. I will be talking about medicinal marijuana next semester when we get into talking about our pain management drugs, because cannabinoids can be used for a whole host of different things, so it makes sense to sort of talk about it over there. But we do have synthetic THC basically. So dronabinol and nabilone are kind of doing the same thing here, where they're trying to mimic the effects of delta 9 tetrahydrocannabinol, which is the psychoactive component of marijuana, right? Which actually oral formulations, you don't have to smoke them like you would like marijuana. So these are typically not going to be used for the majority of patients coming through the doors at the ER, the urgent care for nausea, vomiting, but used quite frequently for chemotherapy. Especially if other agents have failed, or if they have like a chronic nausea, vomiting, then frequently we're going to be utilizing something like dronabinol. And cannabinoids are basically by activating cannabinoid receptors like CB1 receptors up in the brain, can help to decrease activity at the vomiting center. One of the other big benefits of this as well, especially if you imagine someone who has a lot of nausea, vomiting related to chemotherapy, is they're frequently not going to want to eat. If you're nauseous, you don't want to take down any food, and that can affect your nutrition. And so by utilizing cannabinoids, I'm sure most people are familiar with marijuana causing the munchies. By utilizing cannabinoids, it works as an appetite stimulant, and then that allows for basically patients to have better oral intake. So they're getting more calories in, get their nutrients and whatnot, and so that can be a side benefit of that. As far as CNS effects, the same things you expect to see from someone who's utilizing, typical dosage forms of marijuana. You can see some confusion, some euphoria. Next semester we'll talk about kind of the differences between THC and CBD. This is specifically the psychoactive component of marijuana, the THC. This does not contain any cannabidiol or CBD. So you can still see things like mood changes. You can see things like hallucinations rarely, but it's fairly mild as compared to, a lot of like the heavy sedation effects you'll see with things like, your phenothiazines and whatnot. And certainly if you have patients who don't have any problems with appetite stimulations, can cause weight gain for them. So to look at as well. Another way we can try to block signals that cause nausea and vomiting include blocking the activity of something called substance P. Substance P is something your nerves can release that can help to mediate things like pain, but can also mediate nausea and vomiting. And so we have one drug here. It's called a Prepitent or Emend. This is pretty much solely used in for chemoreceptor or chemotherapy related nausea and vomiting, typically to really highly emetogenic drugs like cisplatin, for instance. And so one of the things you'll find, especially with these drugs like cisplatin, is they can cause both an acute phase sort of nausea and vomiting, where they're actually getting the drugs or within the first 24 hours, and they can have a delayed phase. It can happen, 2-3 days out. And so this is why we use a Prepitent, because when it blocks the initial acute vomiting phase and then also the delayed phase as well. And so we'll typically give it over the course of 3 days or so. And so we're going to find that we'll use this in conjunction with other agents like our serotonin blockers, like ondansetron, that work better for the sort of the acute phase, and then the substance P antagonist, like a Prepitent, is better for the delayed phase. And so we're going to block substance P at this NK1 receptor here. And as I mentioned, we'll typically give it the day they get chemo, and then like 2 days afterwards. Do note this does inhibit CYP3A4, so you do have to watch for dosage adjustments with other medications. And it does induce CYP2C9, so less clinically important, but if they're on warfarin or something for some reason. Other agents we can use include things like our corticosteroids, and so frequently you're going to find patients with cancer maybe on corticosteroids because they are immunosuppressant, meaning they block reproduction of white blood cells. So that's one way you might see it being used. But it also has helpful effects on stopping chemo-induced nausea and vomiting. So it kind of can provide some dual benefits there if patients have like leukemia or something like that. So dexamethasone, prednisone. Again, we already know a lot of the side effects of these. So things like weight gain, fluid retention, hyperglycemia, infection, all that stuff still applies here just as well. And then we have our benzodiazepines. These are frequently used as anxiolytics, and so we're going to talk a lot more about benzos later on when we get to the neuro section next semester. But basically, things like lorazepam or Ativan or alprazolam or Xanax are utilized, and this is good for anticipatory nausea vomiting. What I mean by that is basically where if a patient has like received cisplatin before, they had the worst nausea vomiting of their entire life, and they know they're going to get it again. Typically, they get what they call anticipatory nausea vomiting, where they get so anxious that they start to get nauseous and they throw up just at the idea of getting more of that medication, right? So, if you ever had like bad sushi or something, next time you see sushi, you almost get sick to your stomach just smelling it or something, mentioning it. Same thing happens here. And so, by utilizing benzodiazepines beforehand, it works as an anxiolytic, calms them down, and it can help to mitigate that. So, you'll see that occasionally. Again, we'll talk more about these later. Biggest side effects of benzos are definitely going to be sedation, for sure. So basically, we're going to find that how we choose our antiemetics is going to be based on the patient-specific situations. Think about dosage forms too, depending on can they tolerate, oral medications. If they're actively vomiting, then oral might not be the best route. So you might need to utilize IV route. You might utilize the rectal route. So for instance, things like promethazine has a suppository, which can be very useful. They can't take anything orally. Or like ondansetron IV, used all the time in the ER for sure. And then for most cases, if they're just like kind of, they have, a viral illness or something like that causing nausea and vomiting, one agent's probably going to be fine. But if they're having more severe nausea and vomiting, especially due to chemotherapy, that's when they're going to get multiple agents most likely. So it's not uncommon. I'll see a patient getting ondansetron, a Prepitent, dexamethasone, and then Ativan, lorazepam as well, all in combination to try to prevent that nausea and vomiting. So 4 medications just for one side effect of their chemotherapy, which is pretty wild, but sometimes you gotta do what you gotta do. They're just having pure motion sickness, like if they are going on a cruise or something. Antimuscarinics tend to work better for that. So either something like scopolamine or one of your first generation antihistamines tend to be best for that sort of thing. And then the 5-HT3 receptor antagonists are really good for run-of-the-mill acute nausea vomiting, working in the urgent care, ER, anywhere like that. Totally fine to utilize something like ondansetron, very safe, non-sedating. That'll get good good mileage out of those drugs there. All right. So other things we could do as well. What if we wanted to stimulate the GI tract to move along? And so that can be sometimes a cause for nausea, vomiting, is if you have patients who are not having good peristalsis and moving things throughout the GI tract. And so this is where we can utilize prokinetic drugs. So you'll see this sometimes in patients with gastroparesis due to um, diabetic neuropathies of the GI tract, where they can cause basically stuff is just sitting out in the stomach and not being moved along, and so then they vomit that up. And so if you ever see someone vomiting kind of looking undigested sort of food, that's probably a sign of gastroparesis. And so one of the things we can do there is called metoclopramide, which we talked about as being a dopamine receptor antagonist. And so this actually causes an increase in acetylcholine release. By blocking D2 receptors, which normally D2 suppresses acetylcholine release, by blocking that, you have an upregulation of acetylcholine that interacts with the muscarinic receptors in the GI tract, which causes prokinetic actions. You're going to cause more gastric emptying, more GI motility, all of that stuff to cause food to get moved through. So frequently used for GERD, gastroparesis. Again, the same side effects still apply here. So you can still see some dizziness, fatigue, sedation. And again, very rarely would you see any kind of Parkinson-like effects or neuroleptic malignant syndrome, but you could see it potentially. Another drug, which you might not normally think about, is going to be erythromycin, which is our macrolide antibiotic. And this actually interacts with motilin receptors on the GI tract to help kind of force things through. And so I do see this quite a bit for pediatric patients. And in fact, 9 times out of 10, if I see a patient who's on erythromycin in the peds hospital, it's going to be for promotility as opposed to its use as an antibiotic. So if you see someone who's on erythromycin scheduled with no end date on it, it's probably for its prokinetic effects there. So that can be very useful for those purposes. But again, it's kind of a double-edged sword because it can cause cramps. And you can see some effects over time to where you can actually impair motility. So again, you may want to use it on a limited time course, but I'd usually leave that at the discretion of colleagues. All right. Then we'll talk about laxatives real quick. So if we have patients who are having constipation, how can we get things moving along? And so lots of reasons for constipation. Some of it can be more functional. Some of it can be more psychological. Some of it can be due to medications. I wonder why hypercalcemia is misspelled. So anyway, so a whole lot of causes here. In terms of drug-induced causes, because again, you frequently don't want to give more medications to treat drug-induced causes of things, but sometimes you have to. So things like opioids, anticholinergics, antacids, iron, calcium channel blockers, a lot of medications. And very frequently, these patients are going to be on multiples of these drugs, causing constipation. So definitely want to be careful with these, but we'll look at some ways we can try to get around this if we have to have patients on these medications causing constipation. Obviously, what we want to do is try to relieve their symptoms because, again, you can have really severe abdominal cramping and pain associated with this. Try to reestablish their normal bowel habits and increase their quality of life. So a couple of different things we can do here to try to cause defecation to occur. We can try to increase motility. We try to increase the water content of stool. You're going to find many patients with constipation tend to be sort of chronically dehydrated, which makes it more difficult to pass those stools. And then if we can try to decrease the absorption of water and sodium chloride, that's going to lead to a higher osmotic load in the GI tract. It's going to cause more stretch of that tissue there, which can also cause defecation to occur there. So if we can block that reabsorption, that's going to be helpful as well. Now, why do we give laxatives? Certainly for relief of just temporary constipation, but we can also do this if we needed to, say, send a patient for bowel surgery. If we needed to try to get rid of certain toxins more quickly. I just had a patient the other day who was in a car accident after being chased by the police. He apparently had some crack cocaine on him, which he swallowed in a poorly wrapped container, and that was now sitting in his GI tract. And so we wanted to get rid of that faster, so we had medications to try to move that along. So a lot of different reasons for this, especially like in the post-operative period too. This is a huge thing. If you have patients who have received a bunch of opioids during surgery and then they come out, you have to make sure that they are not going to have an ileus afterwards. And so one of the things you use to make sure that they are ready for discharge is that they have defecation, right? They've actually had a bowel movement. And so, this is a big thing as well because the sooner you get those patients out of the hospital, better it is for them because they have less risk for infection. You get more patients moving through, so this is another big deal as well in the post-operative period. So in general, most of the side effects you're going to see are related to sort of that promotility. So you can't see diarrhea, you can't see abdominal cramps, and nausea occasionally. I know if you knew that we had an exam this morning. No one told me you guys had an exam this morning. That's odd. Let's see. I don't know. Yeah. No, no one told me about that. It's been on the schedule all semester. Huh. Well, it's recorded, so you guys can catch back up if you need to. So it's interesting. Oh well, we'll leave it as it is. To talk to Dr. Murray about that. Yeah, I appreciate it. Thank you for letting me know, Joshua. Anyway, one of the other things you want to watch out for with chronic use of laxatives as well is something called cathartic colon syndrome. And so this is seen with patients who are kind of chronically utilizing these laxatives. Basically, if they're kind of using this all the time in order to allow for them to have defecations, they can actually cause damage over time. So you can have things like mucosal inflammation. You can cause atrophy of the outer muscle layers, nerve damage, all kinds of things like that. So you want to make sure the patients are really using this only when needed, instead of this being the sole thing that helps them to have, a bowel movement. So we're gonna have three categories of laxatives. We're gonna have ones that soften the feces in 1 to 3 days. So we'll have our bulk forming agents, our emollients, and osmotic agents. We're gonna have those that result in soft or semi-fluid stool in about 6 to 12 hours. So these are stimulant laxatives, and then those that cause a watery evacuation in 1 to 6 hours. So, and appreciate the flowery language we get to use here. This includes our osmotic laxatives, enemas, and then our bowel clean. We'll have. So in terms of bulk forming laxatives, these are going to be the best for just like everyday sort of use here. Things that, if they've just kind of intermittent constipation, or if they just want to take it every single day to try to prevent constipation, can be really helpful. So these are okay to use every single day, no problem for the most part. Especially good for like elderly patients who may have issues in terms of just occasional constipation. This includes things like your psyllium husk, your methylcellulose, things like that. Typically, these are going to come like powders you mix with water before taking. And what they do is they actually increase the bulk and the water content of stool. And by having that increased stretch and causing sort of that lubricating sort of effect, they increase motility, and so you will definitely see this increased volume causing peristalsis and all of that. So it can be really helpful for those patients. And again, it's not habit forming. It's not going to be a problem. They take it every single day, and most of these are available over the counter, so not too hard to get a hold of. Problems they're going to see is certainly things like flatulence and cramps associated with them, but also they can bind a lot of medications. You got to separate normal routine meds from them taking their other their laxatives here, because they can bind to one another and lead to decreased absorption of those other medications. In terms of stool softeners, these are going to be things that help to emulsify the stool, meaning they help to increase water content and they lubricate. Again, when you have someone who's dehydrated, frequently they get very hard, very dry stools that are more difficult to pass. And again, if they're having pain or having a hard time straining to try to pass these stools, that can cause sort of a psychological thing when they want to try to decrease that pain. And so seeing how it kind of cycles in on itself a little bit there. So stool softeners help to mitigate that, to allow them to pass more easily. So this includes things like mineral oil, glycerin, and then docusate. Now we talk about dosage forms. You're going to see some of these are available orally, where they kind of work from the top down. So things like psyllium husk and whatnot. Some of these are going to be utilized rectally, so they'll be able to work kind of more distally in the GI tract to help movement go along. Some of these can be used both routes. So things like mineral oil, docusate, typically given orally. Glycerin can be used as a suppository. So they all have their different uses there. Now, again, typically the same side effects are going to apply here, some cramping and whatnot. These will not bind medications in the same way that the bulk forming would, so you don't have to worry about that quite as much. Glycerin is typically used for pediatric patients, like under the age of 2. So you have like an infant with occasional constipation due to their diet or something like that. Glycerin suppositories can be really good use for them. Now we do have some stimulants or irritant laxatives, which basically directly irritate the GI tract to cause peristalsis. And so, kind of an old-timey sort of remedy would be something like castor oil, which we don't use too frequently anymore. but certainly things like senna and bisacodyl will directly cause increased colonic motility there. And side effects will include things like abdominal cramping, diarrhea, and the muscle weakness that can occur over time. These are the ones you don't want to use too frequently because if patients take it every single day to cause peristalsis, their own muscles will start to weaken. So if you don't use it, you lose it. This can make it almost impossible for them to have bowel movements on their own. And so you get the rebound constipation, which you definitely do not want to cause for your patients there. So these are very short course, less than a week if you can, to try to avoid that sort of dependence. Then we have some osmotic agents here. So we have things like magnesium sulfate, mag hydroxide, sodium phosphate. You see a lot of electrolyte solutions here you can use. Then things like lactulose and mannitol and polyethylene glycol. These are going to be osmotic agents because they provide a high osmotic load, which can help to draw water into the GI tract and allow for huge, stimulation to defecate. So very helpful there. Fleet's enemas we use all the time in the peds ER, certainly, because you have a lot of kids presenting with abdominal pain. Oftentimes it's just their FOS or full of stool, and so we'll utilize something like a Fleet's enema here. Certainly other things, if you ever say mag hydroxide or milk of magnesia, it's typically an oral product they'll take. We call it the green rocket because it comes in a nice little green bottle. And the second they take it, typically they're off like a rocket to the bathroom. So these are very helpful, very, very good at what they do. Keep in mind though, things like Fleet's enemas, things like that. Anytime you have a neutropenic patient, just like we talked about with the chemotherapy section, do not give any rectally administered drugs. Just one thing to note there. Another thing too is you want to be careful of using any electrolyte solutions in the extremes of age, either very young or very old. Can cause electrolyte disturbances. So, for instance, we've seen cases both in very old and very young patients where they have actually overused things like sodium phosphate enemas and caused fatalities due to hyperphosphatemia. So, one thing to note there. Polyethylene glycol has kind of gotten a lot more use nowadays because of the fact that it's within the past 5 years or so gone over the counter. And so polyethylene glycol can be used for a number of different cases here. In low doses, you could use it every single day and be totally fine. Some patients will do that to try to prevent constipation, much like you would use it as a bulk forming like methylcellulose or something. Or depending on the dose, you can go much higher. And this is where we get into cases like Go Lightly. If you've ever seen it in the hospital, a big 4-liter jug basically of polyethylene glycol they're going to take with water in order to cause a bowel clean out. So if you want to get them ready for surgery in the morning or something like that, you could utilize Go Lightly to clean out the entire GI tract. And then that way, if you need to go and do like a colonoscopy or endoscopy or something like that, everything's cleaned out. So different uses for it depending on the type of dose you want to administer. And so when you're looking at how to treat patients with constipation, again, you want to treat the specific cause. If it's a medication you can get rid of it. If it's due to electrolyte disturbances, fix that first. And then obviously, if we can try to fix the dietary issues, things like increasing water intake, increasing fiber, that's also going to be very helpful. So don't introduce more drugs if you don't need to. Typically, if you can't start out with like an osmotic laxative or an emollient, try for about 2 to 4 weeks or so. So this is like lower dose polyethylene glycol, like Miralax, Docusate, something like that. And then if it's still not happening, there's no bowel movement for about 2 days or so, then you can add on a stimulant. But again, you want to use that for as short a course as possible. So maybe start them out on something like, psyllium husk and water intake at first. If that's not working, try adding on something like an osmotic laxative, say something like that, and that's still not working, they're still not having a bowel movement, then you can utilize something like a senna or bisacodyl. Okay. We will talk about opioid receptor antagonists a little bit later on. This is going to be more of a surgical issue because post-operative opioid-induced constipation is a huge problem. We'll talk about that in the surgery section next semester, so just kind of hang out on that. And then for kind of very acute evacuation of the bowels, that's where we utilize our osmotic enemas. So things like sodium phosphate enemas and whatnot, you're going to be utilizing there. But again, be careful if you have a very old or very young patient. I'm talking like less than 2, usually less than 1. Be very cautious with that there. And then elderly patients, especially those with like, renal dysfunction or something like that, you want to be cautious in them as well. So just something to consider. In terms of antidiarrheal medications, we only have a couple here that we're going to use with any regularity. These basically enhance water absorption and decrease GI motility locally within the GI tract. And so Just as I mentioned, opioids can cause constipation. If we can utilize those receptors, we can also decrease diarrhea. And so we have a couple of drugs here, diphenoxylate and then loperamide. And these are actually going to be drugs that are, while they do work on opioid receptors peripherally, they cannot cross the blood-brain barrier. So you don't get the same sort of high like you would as off of a dose of fentanyl or morphine or something like that. So these can be good to use very occasionally. You don't want to use these chronically because of the fact that you can see things like toxic megacolon that could develop. Um, cramping, abdominal pain, things like that can certainly occur. And again, if they're having diarrhea, it could be for a reason, right? So especially if it's infectious, you don't want them to try to hold on to all those infectious particles and then cause an infection to get worse. So again, use it sparingly. If they're going on vacation and have eating food they've never eaten before, having diarrhea, that can be one thing, but I would not use this more on a chronic basis there. And then something like bismuth subsalicylate or Pepto-Bismol is used occasionally. This is helpful for patients having infectious diarrheas because it helps to decrease intestinal secretions. You do have to take it pretty frequently, though, which can be a negative effect there. And again, we mentioned not utilizing something like this in young children, especially that are post-viral, less than 16 because of the Ray syndrome, because it does contain salicylates. And some patients may develop bismuth toxicity if they're taking this too frequently. But for the most part, it's Pepto-Bismol. Most people don't run into too many issues taking this. And that's it for this section. So I guess you guys all had a test, and I was unawares of that, but that's okay. You guys can go back and watch the video later on, and then we'll kind of go from there. But that's the end of the material for the test. So if you do have questions in the meantime, please feel free to go ahead and reach out to me via email. If you post on the sticky board, I will not see it. Just FYI, I'm not going to check it for the rest of the semester. And then we'll go from there. So get those prescription assignments in, and I will see you all likely next semester. So have a good one. I'll see you then.